Sure, sir.
Basically, I was trained as a pediatrician, and now you can see on screen two of my teachers. One is Dr. Rashid Merchant, who was my teacher in pediatrics, and Dr. Ron Weaver at Holland, who was my teacher in metabolic disorders. So, with their blessings, I entered into what is known as inborn error of metabolism field, and we are actually working in mainly pediatric area, and that too concentrating on newborns. We do a lot of metabolic or biochemical studies in-house, and we have practically almost everything which is required for metabolic workup. We ourselves don't do any genetic studies, but we do have collaborations internationally and nationally. Besides the diagnosis, we also offer help in management and prenatal diagnosis. We have patients with us who are now 20 or 22 years. Basically, this lab is for last 22 years. We started in 1998, and I have an experience of about something like 25,000 children with inborn errors of metabolism. So, without much ado, I will go ahead because this is a little lengthy topic, and to cover it in 30-40 minutes is little tricky. The idea of inborn error of metabolism is not new. When we were students, that time also we had an idea that there is something called inborn errors of metabolism. But we always thought it is so rare that probably we'll never come across. And more we started studying, we realized that actually we see it very often and we do miss it. So the idea is when to suspect, we should not miss. And when to suspect is the most crucial aspect of the entire, you can say, metabolic medicine. Most of the cases go unnoticed. They die as either birth asphyxia or sepsis or what we call sudden infant death syndrome without any known diagnosis. So first two slides now will be the most important for pediatricians. When to suspect. Whenever there is acute illness following a period of normalcy, especially with refusal to feed, vomiting, lethargy, hypotonia, coma, convulsions, intractable hiccups, apnea, respiratory distress, and these are some of the common features or common presentations that we see in newborn period. And maybe we will think that, okay, this is sepsis or this is because of prematurity. This symptomatology is not very specific. It is common to many other conditions. On top of it, there may be associated sepsis. Now, there are some unusual features like unusual odor. Now, I'll not go into details. All the pediatricians know different types of odors which are described in books. We'll come to that little later. Some of the normal or you can say commonly seen presentation like jaundice. It may be a sign of inborn error of metabolism if it is unexplained. Dysmorphic features, organomegaly. Now, history of consanguinity is not necessarily always there, and presence of consanguinity does not mean the child has inborn error of metabolism. So it has got some value, but it is not the, I would say, discriminating feature between inborn error of metabolism and non-inborn error of metabolism. We may get history of sudden infant death also. So when we have these kind of symptoms, I just put in a word, very classical word, that unexplained. If you have anything which is unexplained jaundice, unexplained cyanosis, unexplained death, unexplained seizures, you should start suspecting inborn errors of metabolism. Once you suspect, the next step comes is evaluation. What do you do? Of course, like any other branch of medicine, we start with history, medical history of the baby, with family history. We also do physical examination. And there will be initial screening tests, which are called routine labs or routine tests. Then there may be need of some advanced studies and diagnostic or confirmatory studies. Now, these may be started one after another, or it may be all at the same time. When we take history, one history is very important, that during pregnancy, did mother experience any normal movements. Experienced mother can always tell you that the previous child was not moving so much. This child has excessive movements or something like jittery movements or seizures. We have had couple of patients where mother described that she could feel convulsions inside. So antenatal manifestation can be in the form of increased movements or even reduced movements. And when we have increased movement, there are a couple of conditions we should keep in mind. Glycine encephalopathy, this is one of the commonest conditions. Pyridoxine dependent seizures, serine synthesis defects, asparagine synthase defect, peroxisome biogenesis defect, and molybdenum cofactor. Reduced movements you can see in children with SMA or with mitochondrial, or even sometimes Pompe's people say that there is reduced movements, but I have never come across that kind of history. In wards, we always do clinical examination like facial dysmorphism. We look for cataracts or retinopathies. You can do sonography or, if available, CT scan, MRI for structural brain changes, 2D echo for hypertrophic or dilated cardiomyopathy, organomegalies, and kidneys. Now, I'm not going to go into details of all these because, as I said, it's a very big lecture and we cannot cover the most important part, that is investigation. Even myopathies, brittle hair, abnormal genitalia, coarse facies, these are some of the features we should look for and record it. Abnormal odor is described in textbooks, sometimes like mouse-like odor or cat urine odor or cabbage-like odor. Many people can't differentiate. I can't differentiate. It's like either pleasant odor or unpleasant odor. Most of the unpleasant odors are because of organic acidemias like phenylketonuria or isovaleric acidemia, methylcrotonyl coenzyme carboxylase deficiency. Pleasant odor generally you don't see with inborn errors of metabolism. That is usually seen with high amount of acetone, as is seen with diabetic ketoacidosis. I will not say it is pleasant, but it is some other aromatic smell, which is very typical, like alcoholic smell. Dysmorphic feature. This can be even noted in newborns, and this is very important because it can straight away give you clinical clue. Glutaric aciduria type 2, Menkes-Kinckey hair syndrome, Zellweger syndrome, neonatal adrenoleukodystrophy, or Smith-Lemli-Opitz syndrome. Pay some attention to hair, lysinuric protein intolerance, arginosuccinic aciduria, Menkes-Kinckey hair syndrome, PKU, and biotinidase deficiency. They all have their own typical kind of presentation. Now we are dealing with inborn errors of metabolism in newborn, but little later when the weaning period starts, many IEMs can get precipitated. And if it is associated with weaning, this history is very important. Whether honey or sugar or fructose, or that is fruit juice or anything was given, so look for fructose intolerance, fructose 1,6-diphosphatase deficiency, protein introduction, maybe make a precipitate urea cycle defect, lysinuric protein intolerance, HHH, MSUDs. So history of weaning or any introduction of outside food is very essential. There are some metabolic disorders which are transient. So you may get some abnormal results in the newborn period, but as the child improves or progresses further, the signs and symptoms disappear. You may see this in transient diabetes mellitus, transient hyperammonemia of newborn, what is called transient tyrosinemia of newborn, which is usually seen in preterms, transient glycine encephalopathy, or even congenital lactic lactose intolerance. So most of the time, what I have seen is clinicians or especially junior clinicians, they tend to concentrate first on infection. If infection is there, then there is probably no metabolic disorder. And if there is no infection, they start thinking of metabolic disorder. But you can have both together. And there are certain conditions which predispose to infections. And the most common and the most deadly one is galactosemia. You can encounter even gangrene in that. So it is such a nasty condition galactosemia. Organic acidemia is like methylmalonic acidemia or isovaleric acidemia. Multiple carboxylase deficiency. Glutaric aciduria. Glycine encephalopathy can get affected. Presentation, whether it is immediately after birth or there is a delay. So that history is also very important. If patient is presenting within 24 hours or max 48 hours, we should start thinking about fatty acid defect or mitochondrial disorder, disorders of gluconeogenesis, or even peroxisomal disorder. If there is hiatus of long interval, more than 48 hours or 2 days, 3 days, or even up to 1 week, start thinking about organic acidemias, amino acidopathies, urea cycle disorders, or defects related to sugar metabolism, like galactosemia or even fructose intolerance. So, in nutshell, what basic or advanced investigations we have, I'm not going to read through all these things, but you will notice that there are two separate columns. One is routine laboratory test, which is done routinely, like CBC, platelet, uric acid, cholesterol, LFT, RFT, CSF, sugar, etc. So what I want to concentrate is 5 important tests, that is ammonia, lactate, blood sugar, electrolytes, and blood gases. Now these will decide how you are going to approach to a newborn with suspected inborn error of metabolism. There are various charts available. Some of them are present in my book, which I have written on inborn error of metabolism. And even standard textbooks like Nelson, or I think even neonatology textbooks will give these charts. I'm not going to discuss. I think these PPTs will be available to the audience. So there are 4 charts which I had incorporated. We'll not discuss those. Straight away, let us go to cases. Now, this is a day 2-old male child born out of non-consanguineous marriage, full-term normal delivery, cried immediately. Baby was very floppy at birth and there was no respiratory effort. So, this is the child who presented immediately after birth. Definitely, there was no hypoxia or asphyxia. It was attended in a hospital by a pediatrician and they were very sure that there was nothing. Child was immediately put on ventilator. Child developed jitteriness and hypertonia. There was no sign of sepsis or jaundice. Antenatally, there was no problem noted, but mother definitely described abnormal movements in this child. Basic investigations did not reveal much. Ammonia was normal, lactate was slightly elevated, but child was convulsing. Sugar was normal. Rest everything like blood, CBC, blood gases, electrolytes, ketones were normal. So this is a child who had almost everything normal, and we thought that this could be glycine encephalopathy. And we did amino acids, full amino acids in plasma and CSF. And we noted very high amounts of glycine in plasma and CSF. Now, this is one point which I would like to highlight. Sometimes we get elevated glycine just because child is sick. If child is getting anticonvulsant, you will get high amount of glycine in CSF as well as in plasma. So this is not glycine encephalopathy. The levels, if you notice, they're quite high. Normal range in a newborn can be 350 to 450. And if you notice here, it is more than 1000, 1500. So it has to be more than 1000. And CSF glycine normal is 14. And to call it abnormal, it has to be above 80. So I take ratio as 0.80 or 81. Then we start considering that, okay, this is something abnormal, glycine and so on. But story does not end here. We have to further work up. We do GCMS to rule out other organic acidemias. Now, organic acidemias are known to give high glycine. Anticonvulsants are known to give high glycine. So we must document that there is no organic acidemia. What we see here is hippuric acid, which of course comes with the sodium benzoate because that was treatment. It was given to this child. Sodium benzoate combines with glycine to form hippurate, which is seen in urine. But there is no organic acidemia. Additionally, what we do is pipecolic acid in CSF to rule out pyridoxine-dependent seizures, because there also you can get high glycine. Once that is normal, our clinical suspicion was, yes, it is glycine encephalopathy, or what we call non-ketotic hyperglycemia. As I said initially, we must do confirmatory studies. We have to have this because prenatal diagnosis will be very important. And in this child, there was defect in GLDC gene. Baby was homozygous, both parents were heterozygous. So it was a pakka case of glycine encephalopathy. Now, there are many other genes associated with glycine encephalopathy. I have listed them, and this list probably will increase in future. If you see, it's a very complex kind of system, glycine cleavage system, and there are 3 proteins, T, T, and L, which are associated with defects. And if you can see, pyridoxal 5-phosphate is a cofactor for this GLDC protein, and therefore, if there is pyridoxine deficiency, you can still get elevated glycine and presentation like glycine encephalopathy. There are other genes involved in the whole system, and many of them are iron sulfur cluster system. So it will give a very complex kind of presentation, and this is called variant glycine encephalopathy. I will not go into that, but just remember that it will be a combination of both pure glycine cleavage system plus iron sulfur cluster defect. So if we put these 5 important points, which we start with, that is ammonia, lactate, sugar, ketones, and blood gases, we can identify or we can suspect inborn error of metabolism and group them into 6 different groups, which helps us in diagnosis. What is group 1 is where you get everything normal. Normal ammonia, normal lactate, normal sugar, normal ketones, no acidosis. Now here there is a caveat that if baby is convulsing and you have collected sample during convulsions, there may be some amount of lactate elevation. So that does not qualify it to go into another group. Group 1 will be typically like most of the results will be normal. And we have almost 25 differential diagnoses in this group. This is what is very important, especially in critically ill babies, where we do basic studies and we do not find anything. And we start thinking, oh, it may not be inborn error of metabolism, it may be something else. But precisely this is the group where you have 25 differential diagnoses. I have enlisted 11, which are the most common. But if anybody wants, I can send you the list. There are 25 different conditions we know which can present with what is called group 1 neurotoxicity syndrome. Group 1, in short, means everything practically normal. And what do we do here? We ask for CSF full amino acids, plasma, CSF, or urine, pipeculic acid, ASA, EG, very long chain fatty acids, urine pyrimidines. So there is a huge list of things which we may have to do. It's not that only TMS is the diagnostic test. Please remember, TMS is only a screening test. And whenever we send TMS, we want to rule out those common 40 or 50 disorders. Now we are talking about 1,500 plus disorders. So diagnostic testing is different than newborn screening. Please do not mix up. Many of the metabolic disorders cannot be picked up by newborn screening. So we have to remember that diagnostic test is for diagnosis. Now let's go to group 2 or second case. This is a 1-month-old female child born out of third-degree consanguineous marriage. Full-term normal delivery tried immediately with history of lethargy, vomiting, convulsions from 7-day onwards. Now, when we have history that there is a hiatus of 7 days, it means there is something related to food, either protein, fat, or sugar. Ketones were strongly positive. Ammonia, lactate, sugar were normal, and there was no acidity. DNPH was positive.
Singh, kindly mute all.
TMS had shown high leucine.
Sir, please unmute yourself, sir.
Unmute. Unmute. Unmute.
Can you hear?
Yes, sir. Yes,
Yeah.
sir.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Okay. So this was a child. Should I go to previous slide?
No, 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 sir. Same, sir. Same, sir. You
Okay.
can continue.
Okay. So this was a child who presented after a gap of 7 days with encephalopathy, and there was ketones in urine and nothing else. Everything else was normal. We had, or we can have normal or mildly elevated ammonia, normal lactate, no acidosis, blood counts normal, and ketones positive. This is a group where you will get typically high ketones, and there is usually only one condition which can be considered, that is MSUD, maple syrup urine disease. Now, you get elevation of leucine in other conditions also. I'll just come to that. GCMS is very diagnostic. What we look for is 2-oxoisocaproic acid. That's the diagnostic marker. But there are many other markers. This is a clinicians meeting, so I will not discuss on biochemistry. But just remember, unless and until I document these keto acids, my diagnosis of MSUD is not confirmed. High leucine, or on TMS, what you see is leucine, isoleucine, and allo-isoleucine combination. That can be seen with maple syrup urine disease. And there are two other conditions, what is known as hydroxyprolinemia and branch-chain keto acid deaminase deficiency, which is the first step before this dehydrogenase stage. You get elevated leucine, valine, isoleucine, but you do not get keto acids. So this is one condition where you will get elevation of this branch-chain amino acid, but no keto acid. So diagnosis is done not by TMS alone, but by additionally GCMS. So please always confirm with GCMS, confirm with the molecular studies, and then continue your treatment lifelong. This is the second group. Second group has typically high ketones. First group was where everything else, everything was normal. Second group is everything normal except ketones. Now let's come to third group. This is 2.5-month-old female child born out of third-degree consanguineous marriage. History of intractable seizures for 15 days. History of hair fall almost to the tune of alopecia. There was no failure to thrive. This is very important. No failure to thrive. There were skin lesions, eczematous lesions, and no significant family history. Ammonia was mildly elevated. Lactate was elevated. Sugar was low. Ketone was absent, but this sample we received from a very long distance. When we did further studies, we found there is elevation of what is known as isoaryl carnitine or C5OH, and biochemistry documented deficiency of biotinidase enzyme. Now, this is a very common condition that we see in India. It is confirmed with GCMS of urine and enzyme analysis. GCMS will show 3-hydroxyisovaleric acid. Please remember, there are 6 conditions at least which can give high C5OH or isoaryl carnitine. So GCMS is very important to rule out other disorders like 3-methylglutaconic aciduria, HMG coenzyme L deficiency, and multiple carboxylase deficiency. So we need to document that there is everything else which is normal, but only biotinidase deficiency. Now, this is the child who had severe alopecia. At 6 months, you will notice that she is quite plump. She was 8 kg and responded beautifully to biotin supplement. Immediately after supplement, within 1 month, everything settled down. Normal milestones, no seizures, good hair growth, child is playful, but deafness. So please remember, in biotinidase deficiency, the complications which can happen is you can get deafness, convulsions may continue, so we need to address to it. Some children have ataxia also and learning disability. Treatment is done with biotin tablet, usually starting with 10 to 20 milligrams, but some children may need higher doses, even up to 80 milligrams per day. It's not per kg. Carnitine 100 milligram per kg per day may be given initially, or depending on the results. This particular child still needs. The moment we reduce carnitine, she starts having problems, and mother says, I will not stop, because she gets into problems. She becomes very restless, ataxic, and her behavior worsens. So this is helpful in some children, but not in all. This is fourth group. This is one baby, MD, 1 month old female child born out of non-consanguineous marriage, presented with vomiting and loose motion, and one episode of seizure. Child had drowsiness, but here there were signs of dehydration and metabolic acidosis. Ammonia was mildly elevated. If you notice, normal is up to 33 micromoles per liter, and she was around 64, not very high. Lactate was again mildly elevated. Normal is 2.1, this child at 4.5. Blood sugar was low, ketones were present, and there was acidosis. So if we take our 5 parameters, ammonia, lactate, sugar, blood gas, electrolyte, all are abnormal. When you have everything abnormal, it is group 3, which is typically organic acidemia group. We did TMS for this and found that propionyl carnitine is high, and then confirmed with further analysis that is methylmalonic acid, which was seen on urine, and quantitation was done. It was confirmed to be mutase 0. Child had very high levels of urinary methylmalonic acid and plasma methylmalonic acid. So GCMS here again very helpful in organic acidemia. TMS alone may or may not give a diagnosis. So please always, whenever you have group 3, please go for TMS plus GCMS plus maybe amino acids will be required, because that is important for treatment. When we give specific treatment for these conditions, we need to monitor amino acids. Propionic acidemia again can show this propionyl glycine. So there are markers. In isovaleric acidemia, you see isovaleric glycine. Treatment is very standard. We give low protein, high calorie diet. There are special formulas available like MMA, PA formula, or even butyric aciduria formula, isovaleric aciduria formula. Injection B12, carnitine, biotin, and bicarbonate. Bicarbonate is very important. They have continuous production of acid, so we must supplement bicarb. And if we don't supplement, the weight gain is not very good. But when we supplement, we have to be very careful and monitor blood electrolytes, monitor urinary and blood creatinine, because many of these children go into renal failure. So this is very important to monitor. So this is group 3, where you have almost all the parameters are normal: ammonia, lactate, blood sugar, blood gases, ketones. Even there may be leukopenia or thrombocytopenia. Some kids can present with high blood sugar. So please remember, if something looks like diabetic ketoacidosis, please do GCMS and rule out organic acidemia. We have had a couple of children, those were treated with insulin, but later on they were confirmed to have methylmalonic or isovaleric acidemia. So this is a very big group, at least 22 different disorders. I have mentioned 4. Methylmalonic is commonest in India. Propionic, isovaleric, multiple carboxylase deficiency or biotinidase deficiency. And there are about 17, 18 more disorders. So this is group 3. Now let's come to next group. This is a female child born out of cesarean and non-consanguineous marriage. Birth weight was 3.5 kg. Developed lethargy, refusal to feed, and altered sensorium on day 3 of life. One elder female SIB is normal and there was an abortion. Sepsis workup was normal. So again here we see a good healthy child and developing symptom after a hiatus of 48 hours. So there has to be something related to feeding. Maybe protein, maybe sugar, maybe fat. Basic workup was normal, but if you see ammonia is quite high. Now, one thing I would like to highlight, in a sick child, you may get some amount of ammonia elevation. If the normal range in my lab is 33, I will disregard up to say 60 or 70 or even 100 in a very preterm baby. But if it is more than that, definitely I will consider one of the differential as inborn error of metabolism. If child is quite sick and cerebral edema, there may be some amount of lactate elevation. But essentially, there was high ammonia and no acidosis. EG had shown burst suppression pattern. Because we suspected urea cycle defect, did orotic acid, which was high. Normal is 11 and this child had shown 202. So we are pretty sure that it is distal urea cycle defect. Citrulline was 1400 and plasma argininosuccinic acid was normal. So whenever we have high citrulline, we have to rule out argininosuccinic aciduria because the treatment is different, outcome is different, and sometimes even diet management is slightly different. So when we have this suspicion of urea cycle defect, next we go for genetic studies. Here it was confirmed to be compound heterozygote, both parents were carriers. And this child was treated. Unfortunately, we lost this child at the age of 12 years. She was doing pretty well and developed some kind of CNS infection, and this child succumbed. So this is group 4, where you have predominantly high ammonia. Lactate may or may not be elevated. There is no acidosis, rather alkalosis. Sugars are normal, blood counts are okay, no ketones. And this is what we call group 4 or something which is like urea cycle defect. The commonest disorder here is those 8 disorders which can be seen in urea cycle disorder. But fatty acid oxidation defects can present like this. So we must remember FAOD can present, especially conditions like long chain fatty acid defects. LCHAD, VLCAD, or CPT2, or CACT, even GA type 2. They can present like this. That was group 4. Now let's come to group 5. This is one baby of SR, 2 days old male child born out of non-consanguineous marriage. Predominantly had hepatomegaly, jaundice, and bleeding starting on 2nd day, and it went on up to 6th day. Previous 2 children expired with similar fees. Now this is non-consanguineous, but you get similar history. One of them was suspected to have tyrosinemia, and second one was neonatal hemochromatosis. There was a suspicion, but nothing was done or for confirmatory testing. In this child, what we found, ammonia was mildly elevated, which, as I said, in a sick newborn you may consider, but lactate was definitely high, 8.3, which is almost 4 times. Blood sugar was on the lower side, and LFT was grossly abnormal, liver function test. Serum ferritin was done, which was 1000, so above the cutoff of 1000, which we take for these kind of disorders. Amino acids had shown elevated methionine, tyrosine, and there was some amount of alanine elevation. So these are the same reports. Next we do is GCMS of urine, and what was seen was grossly elevated lactate and pyruvate. There was no succinyl acetone. Somebody would have thought of tyrosinemia type 1. One hint I would like to give, if you suspect tyrosinemia in less than 1 week child, mostly will be wrong. They are either mitochondrial DNA depletion syndrome or some other liver disease, even galactosemia, HLH. But tyrosinemia type 1 usually presents after 4 to 6 weeks. Typically, they present late and they have a lot of irritability. I will come to that. But here it is very acute onset. Starting from 2nd day, child expired by 7th day. So this is very unlikely to be tyrosinemia type 1, and we need to confirm, of course, and it was shown that succinyl acetone was normal. We did many other things, but because of elevation of lactate, pyruvate, methionine, tyrosine, and ferritin, this is a very typical combination suggesting mitochondrial DNA depletion syndrome. And if you do GCMS, it's almost indicative that you have very high lactate, very high pyruvate. There are ketones, even fumaric acid, succinic acid. So this suggests that we are dealing with this. Now parents were very keen on diagnosis, so we planned for liver biopsy. And this is one very important point we should remember. If we are planning for liver biopsy, please arrange for electron microscopy. You need to ask from a lab which does electron microscopy, 3% glutaraldehyde. Keep it in the fridge. You may do it ante-mortem, you may do it immediately post-mortem. In this child, it was done immediately post-mortem. So liver biopsy was done, which showed typical changes which are seen in mitochondrial DNA depletion. They are not diagnostic of DNA depletion, but they are very suggestive. What is called oncocytic changes, loss of normal cristae, iron particles, iron deposition. So this is a normal mitochondria that we see with lot of good cristae and good size mitochondria. But here you see a lot of, in this child's biopsy, what we see is a lot of ghost kind of appearance of mitochondria. They are empty. There is no crystal inside. And these dark particles, they are iron deposits. So what we see is the liver biopsy is crowded with mitochondria, loss of crystal, loss of shape, and iron deposition. This is very suggestive of mitochondrial DNA depletion. Of course, we need molecular studies to confirm. And one of the two commonest gene defects, DGUOK and MPV17, these are two commonest defects which are associated with this kind of presentation. Unfortunately, there is no treatment for this. Most of these babies die. Some of them improve, and we know some cases which have been transplanted, but it is generally accepted fact that transplant in such babies is not going to be very useful. So this helps whenever we have this diagnosis. This will actually help us in avoiding liver transplant in such cases, which most likely these children are not going to go. They will die. So this is the fifth group, which is mainly the lactate presentation. You have either hepatomegaly or hepatic involvement or CNS involvement. Child may present with encephalopathy. The biomarker or metabolite which is striking is high lactate. There may be some amount of ammonia elevation, there may be some ketones, acidosis. But what sticks out as a sore thumb is lactate, persistently elevated lactate. Unfortunately, this is a very big group. There are more than 200 conditions in that, and I cannot enumerate all of them. But please remember, these are some of the commonest conditions: pyruvate carboxylase deficiency, pyruvate dehydrogenase deficiency, respiratory chain defects, and mitochondrial defects, mitochondrial DNA depletion. Though people try to treat with what is known as mitochondrial cocktail, the results are not very good. We use coenzyme Q10 or B50, which is available from international market. Vitamin C, vitamin E, carnitine, alpha lipoic acid. What will work, we don't know. So we give it. Some children improve, some don't improve. We have to try. The last group. This is 2-year-old male child presented. Is born out of third-degree consanguineous marriage. History of failure to thrive and irritability that started at 1.5 months of age. This is the history which mother gives. History of delayed motor milestones, hypotonia, rickets. Now, children may present early also. Previous 2 children expired with liver disease. So, presentation is mainly hepatic. We found mildly elevated HGOT, PT, and very high alkaline phosphatase. What we did was tyrosinemia profile. That means we looked at succinyl acetone in blood and urine. Normal ranges are less than 0.1, and in urine it is less than 1. And you can notice that it's very high, 38 in blood and 296 in urine. So this was suggestive. GCMS had shown elevated succinyl acetone, and we used this succinyl acetone for quantification. Please remember, whenever you want to send this sample, send it in ice. Succinyl acetone is very volatile. But we have picked up succinyl acetone even from the samples which we received from Gulf countries, and they come at almost 50-degree temperature. But the values may be very low. So this will not be always possible to determine. It's always better to send it in ice or coolant gels. Treatment is very standard. NTBC is now available. Unfortunately, not at compassionate basis. Previously, we used to get it, but now it is commercially available. Low protein, high calorie diet, special tyrosinemia formula. We need to treat acidosis, which is very much there, and it lasts for almost 1 to 2 years. Some children may need it even longer, 2 to 3 years or 4 years. Calcium and vitamin D supplementations and multivitamin. So this was the child when he presented. This was in 2004. And this is after 6 months. So you can see remarkable improvement. Child general condition improved. Now child is around, I think, 14, 15 years and is in excellent health. Unfortunately, he developed hepatocellular carcinoma HCC, which is known in these kind of children because we treat late. If it is detected in early infancy, that is within 1 month, then probably we will be able to avoid this kind of complication. After that, succinylacetone will reduce or maybe you can say delay HCC, but it cannot avoid totally. Some children will get it. So we need to keep a watch on that. And it's better, some people feel that it's better to do liver transplant once the child is in good condition, so that we don't have to do it on emergency basis. Post-transplant, there may be some amount of succinylacetone seen, like this child. Post-transplant, we had some amount. And some of the consultants feel that we need to give NTBC in a very low dose. So this is the sixth group, where the presentation is mainly hepatic with or without jaundice. There may or may not be liver cell failure. It may come later on. Ammonia, lactate, ketones, blood sugar, they may be abnormal. So we discussed about 6 groups. First is without any abnormality, which is like glycine encephalopathy, or there are so many other conditions. Second group is high ketones, which is MSUD. Third group is all the things abnormal, which is organic acidemia. Fourth is mainly high ammonia, which is urea cycle defect. Fifth is high lactate, which is mitochondrial disorders. Sixth is mainly hepatic, and we have a list of at least 10 to 12 conditions. Most common treatable conditions, please do not forget galactosemia, tyrosinemia, fructose 1,6 diphosphatase deficiency. Unfortunately, fructose aldolase deficiency is difficult to pick up by biochemistry. There are ways, but then nowadays genetics is even better. So for such conditions, we have to go for that. This is one case which I would like to share if we have time. This is given by Dr. Ashwath from Coimbatore. He's a very senior consultant pediatrician. Very interesting case. Baby HK born out of third-degree consanguineous marriage. This is third born. 2 previous children or babies expired in the neonatal period with history of excessive cry and irritability. This child presented at 2 months of age with excessive cry and irritability for last 20 days. That means around 4 to 5 weeks, this child must have started all this. There were no other complaints like altered sensorium, seizures, or abdominal distension, no obvious organomegaly, no edema, pallor, jaundice, etc. Basic investigations were done. Child had low hemoglobin, high blood counts, CRP was elevated, ammonia was elevated, lactate was elevated. There was some amount of acidosis and bicarbonate. So this was kind of mixed presentation. And why I am trying to show this, that patient will not come with the classical textbook picture of group 1 or group 2 or group 3. Babies don't know these classifications. So they will come as a complex phenomena, and this is a complex presentation where child has been suffering for 20 days, and what has happened in those 20 days we don't know. So what was done was, besides these studies, PT, PTT were done, which were abnormal. Blood culture came positive with Acinetobacter, and sepsis was suspected, but there was obviously something else. So Dr. Ashwath called me and asked whether we can do something about it. This was the initial LFT, where you notice that HGPT or ALT was okay, normal. There was mainly indirect hyperbilirubinemia and slightly low protein and albumin. But when we did on the sample after, say, 4 or 5 days, this sample was collected 5 days after the first. You notice the change. There is increase in SGPT, there is increase in alkaline phosphatase, and there is reduction in albumin. So this child was deteriorating. And definitely there was abnormality. We went ahead and did TMS, which showed high methionine, only methionine elevation. So this suggests that there is a liver involvement. We did GCMS, which showed very high levels of succinylacetone. There was no jaundice. There was nothing like hepatomegaly or cirrhosis. Only irritability. We did succinylacetone quantitation, which was 38. Normal is less than 1. So this was obviously a confirmed case. So we wanted to see why there is so much of irritability, and we did porphyria screening. So ALA and PBG, delta amino levulinic acid, normal is less than 56 and this child had 540. It's almost 10 times, which is suggestive of porphyria. But porphobilinogen or PBG was normal. So this suggests, yes, we are dealing with what is called as tyrosinemia type 1, and where we get, this is PBG and this is ALA. You see colorless, which is PBG is normal. This is a actual porphyria patient where both are elevated. So whenever we have elevation of ALA but normal PBG, DOS porphyria, lead poisoning, and tyrosinemia type 1. These are the three differentials, and for elevated ALA and PBG, it is one of those three porphyrias. We will not be discussing porphyria here. The point which I want to make is this child had probably severe abdominal pain because ALA is known to give all this pain and neurological symptoms in porphyria patients. AFP was elevated. We have to correlate with the normal range for the age. This is one point which I would like to highlight, especially for residents. Please look at the normal ranges of AFP for the ages. This is for preterm baby, red in red color. What you see. It takes 3 months to normalize. So if you have a child who is say 1 week or 2 weeks, the AFP will be high. We need to see what is the range and whether it is above that. Typically in newborn, anything above 70,000 in a healthy newborn, I will take abnormal, and more than 200,000 in a preterm, I will take abnormal. So here we did that suction assessment. This is the last case actually. So hypermethylanemia you see in prematurity, liver dysfunction, mitochondrial DNA depletion, etc. And there are many other conditions where we get high methionine. This is one of the things which can happen with newborn screening sample when you send and it comes back as elevated methionine, and we need to do a lot of studies to confirm whether there is a real inborn error of metabolism or it is just a prematurity or some kind of liver pathology, infection or something which is giving rise to high methionine. This is a flow chart. I think when you get the slides, probably you will get this also. And there is a way to work up. Dr. Prashant, should I stop or just one last case is there? Okay, I'll just finish off. This is 11. Yeah, tell me. If you want,
Please
I can
go ahead,
stop.
sir. Please go ahead, sir.
Okay.
Please
Okay.
go
So
ahead,
this is the last case. There are 8 or 10 slides. That's it. So this is the 11-month-old child born out of non-consanguineous marriage. This is the 5th pregnancy. Now, there is always a message in these kind of cases. As I said, patient will not come with the diagnosis or group that I am 2nd group or 3rd group or 4th group. There will always be a complex phenomena. And history will be sometimes very important, but sometimes confusing. So this is that illustration. 5th pregnancy, 2 previous abortions, 1 female sibling of 13 years is normal, 1 male sibling expired with renal dysgenesis and renal failure at the age of 4.5 years. Now, this child was brought to us. This is courtesy Dr. Pranati Gatta from Hyderabad. So, this child was presented with hypotonia, swallowing difficulty, recurrent diarrhea, gross motor delay. Now, he started very early in life, almost in the neonatal period. And he went from pillar to post, many physicians had seen. And somebody suspected that this is food intolerance or lactose intolerance, so milk was changed. Child was on Neocate when he came to us on hydrolyzed formula. And there was some metabolic studies done, I'll show you. Ammonia, lactate, blood sugar, everything was normal. What was done was TMS, which was done 2-3 times, and it always showed C4 or butyryl carnitine, which is elevated. Now, if we remember, butyryl carnitine is marker for short chain acyl coenzyme dehydrogenase or something what is known as SCAD. But it is considered a non-disease. People don't think that this is a real problem or this is a real disease. And here we have a child who has biochemical analysis and even genetic analysis showing that there is a SCAD. Why is he so symptomatic? He was treated with carnitine, riboflavin, and fat-restricted diet. He was also taking Neocate. So this child was, when he came, I think around 9 months or 11 months, mother brought in her lap and he was not able to even hold his head. we again wanted to repeat because that's the best thing you should do. If you suspect metabolic disorder and you are not clear, you should repeat. So we repeated TMS, found the same thing, C4 that is butyryl carnitine elevated, but GCMS showed very high level of ethyl malonic acid, which was not seen in the previous two GCMS reports. So this is the importance of repeating it. Metabolic studies are not like genetic studies. They may change from time to time, they may change with diet, they may change with catabolic state. So if you are in suspicion, please repeat it. Here what we did is quantitation of ethyl malonic acid by LCMS, and we found that blood ethyl malonic was almost 20 times elevated, and in urine it was 14 times elevated. So it was a biochemical diagnosis of ethyl malonic aciduria. This is the flow chart, this follow-up chart. For ethyl malonic aciduria, there is a way to treat. I'll come to that. But notice the difference. Once the treatment is started, the GCMS improved. Ethyl malonic acid almost reduced to something like non-detectable and then minimal normal level, less than 10. And in blood also, it started reducing from 20, it came to 2. What we did was added coenzyme Q, N-acetylcysteine, and metronidazole. There are beautiful papers on internet. If somebody is interested, can go through that, or I will send it. And this is the specific treatment. If you have ethyl malonic aciduria, treat with coenzyme Q, N-acetylcysteine, and metronidazole. And the results were remarkable. Child started gaining weight. After 3 months, when child came, he was holding his head. He was sitting without support. There were no more loose motions. Mother started giving him normal food, normal milk. After 6 months, this child came walking. He was running all over, and he had normal intake. No special formulas, no fat restriction. He was taking almost everything. So metabolic disorders, as I say, they are quite complex, but we have a very systematic way to work up, and we can definitely identify most of them, at least help them in diagnosis, help them in prenatal diagnosis, and if treated in time, we can save them. Thank you very much.
Thank you, sir. Wonderful presentation, sir. We will take up the discussion after the next presentation.
Okay, sir. I'll be logged in.
Yes, sir. Yes, sir. Yes, sir. So once Dr. Tejal's presentation is done, then we'll take up questions for discussion.
Okay, sir.
Wonderful presentation, sir. And you are such a well-renowned person all over India, and we all know you, and we are very, very proud of you. It's a wonderful opportunity to hear you. Thank you very much, sir.
Thank you very much.
I request Dr. Tejal. Dr. Tejal.
Hello.
Yeah. You can start sharing your slide.
Yes, I will.
Dr. Tejal is a very dynamic, young, a wonderful speaker, and whenever she picks up the mic, she just smashes the occasion. She's too good, and it's indeed, we have given a very good topic for a perfect person. And we have heard from her speaking about echo. We have heard from her speaking about infection. Now it's time to listen about the genetics. Thank you very much for accepting our request to you being our presenter for the session. On behalf of NNF Karnataka, we would like to give you a very, very warm welcome, Dr. Tejal. Dr. Tejal is a chief neonatologist at Fortis Hospital, Bannerghatta. So, Dr. Tejal?
Yeah.
Yeah, you can start sharing your slide.
Yes, I'm just trying to do that.
Yeah. Once her presentation is done, then combined we'll take up questions for discussion. And the good news is we are coming up with SOP for COVID-19 newborn care management with association with UNICEF and the NNF Karnataka and Government of Karnataka. And this SOP will be circulated to all the SNCUs across the state. So we are working towards it, and we are trying to collect all data available from the resource and from our people of NNF Karnataka as well. So once it is ready and once it is published, we will announce it here as well in our web series. And we will, it will be made available to all the people who are there, part of our Facebook group as well. Dr. Tejal, are you able
Yeah.
to start sharing the slides? Dinekar sir?
Prashant?
Yes, sir. Yes, sir. If you have any questions has been sent to you, you can start till Dr. Tejal starts presentation.
Presentation. Anil sir, how are you, sir?
Yeah, I think Tejal, you are able to start sharing the slide. Yeah. Sir, yes, sir. Yes. We can see the
I'm trying to
screen.
share the slides.
Yeah,
Dr.
you
Prashant.
minimize the screen. What you have pressed now, you minimize the Microsoft Team, and then start clicking on the presentation. Or otherwise, you minimize first, then you click on the presentation, then you maximize the
Correct.
Microsoft Team page, and then start press the share button. You'll be able to see that in the bottom.
Yeah. Okay.
Prashant?
Yes, sir. Yes, sir. Meanwhile, you can start if any questions.
Yeah,
are.
1 second. Everybody,
Yes, sir.
I think so. Thank you very much, Dr. Prashant. Anil sir, thank you very much. Tejal, very good. Keep pressing the buttons. Somewhere something will open. Don't worry. Okay. All the best. Dear, no, we are all waiting for your talk. So you are the last batsman of this session's program. You are the last batsman.
The season, the finale.
Okay,
Sir.
and from 22nd of this month, 22nd, then 29th, then August 5th, from England, who invented amplitude EEG. Amplitude EEG. On 22nd, we are having about the talk from 7 o'clock to 9 o'clock about amplitude EEG. Then 27th, we are having one more talk on amplitude EEG, more than a HIE in the preterm baby and IEM disease. Then August 5th means weekly once we are planning to do all the abroad speakers we are planning to bring to talk about only amplitude EEG. So it will be very good. It is also sponsored from the NNF Karnataka. Okay, it will be very good talk. All the best, Dr. Prashant Gowda. You are really doing great. Number one, and always persistence. See, only success. If you want success, not only hard work, but it needs persistence too. You are really having the persistence. Hats off to you. Good motivation by
it's a team
motivation
effort,
by
sir.
Dr. Kutesh, sir. Have you
Yes,
called
sir,
Kutesh,
yes,
doctor?
Kutesh sir would have joined now, sir.
Yeah,
No.
yeah,
Saw
I'm
him,
online.
sir. Yes, sir. Yes, sir.
Yeah. So
Okay.
team
Dr.
effort,
Kutesh
sir.
has motivated you very much.
Yes, sir.
Dr. Kishore Kumar also call all our joint secretaries. I
Yes,
think
sir.
so.
Yes,
We
sir.
will
It's
end
all
up
because
today.
of all of them, sir.
Please call everybody together today after the
Yes,
Tejal.
sir.
Tejal, are you ready, dear?
Yes, sir. I think Tejal is ready.
All the best. All the best, Dr. Tejal.
Dr. Tejal, over to you. Over to you.
So, very good evening to all of you, and I would sincerely like to thank NNF Karnataka, Dr. Prashant, Dr. Dinakar, for this wonderful opportunity. You've assigned me a very intriguing topic, and I'll try to do some justice to it. I know it will be hard to follow Dr. Jalan's talk, but I hope this talk will have you all as enthused as I was in this topic. So I'm going to be talking about genetic screening in the newborn, and I hope I'm audible.
Yeah. You are audible. Please go ahead.
Yeah. So genetic disorders in the neonate, as such, they pose a significant challenge to diagnosis. Number one, because there's a poor index of suspicion. Features can be very non-specific in the newborn period. There may be limitations to clinical examination of the newborn, given the acuity of illness. Also, there is the question of phenotypic variability. Given the incomplete penetrance and variable expressivity of autosomal recessive disorders, the same disorder can present with multiple phenotypes, some more milder than the other. There's also genetic heterogeneity between disorders that present with a very similar clinical phenotype. So you may have babies with very similar phenotypes, but the the genotype is quite heterogeneous. So given all these, genetic disorders per se are difficult and challenging to diagnose in the newborn period. So I will just take you all quickly through some of the genetic diagnostic techniques that are currently available. You're all already aware of these, so I'll go through this fast, but just a quick recap. We all are aware of what the karyotype is. It looks at the metaphase spread of chromosomes. It is good at diagnosing aneuploidies, chromosomal abnormalities, and whole genome imbalances like triploidies and tetraploidies. The disadvantage with this is it has limited resolution. Another technique which we are all aware of is the FISH, where probes are used to examine very specific segments of the genome. So you have to have a very high index of suspicion for what disorder you're looking for. So this technique is good at diagnosing submicroscopic deletions, duplications. It has a better resolution than the karyotype. Techniques that cast a wider net over the genome, such as the chromosomal microarray, which can be an array hybridization technique. It looks at the entire genome, but it looks at gains and losses throughout the genome. And this technique is good at diagnosing aneuploidies, copy number variants, and is also a first-year test when you're looking to diagnose babies with, those with developmental disabilities, intellectual disabilities, autism spectrum disorders. For those, it is said to be a first-year test because it casts a wider net over the genome, helping you look for all these abnormalities in the genome. But it is unable to detect whole genome imbalances. Other DNA sequencing techniques that look at single gene defects. Sanger technique, Sanger sequencing has been around for a long time. It has a longer turnaround time and it looks at specific genes. But of late, the newer generation sequencing techniques that have come up that can look at single gene defects throughout the genome, throughout the exome, and they have shorter turnaround times. The only thing that they have difficulty delineating are trinucleotide repeats, imprinting disorders, and although we call it whole genome sequencing, it is not necessarily looking at the whole genome. There are areas of the genome that it is not able to completely evaluate. So with this, having said this, so when we look at diagnosing a newborn with a suspected genetic disorder in the NICU, if a specific syndrome is recognized, then it is always better to go on with the techniques that are specific, such as a karyotype or FISH. If a specific syndrome is not recognized, then you will have to use one of those techniques that cast a wider net over the genome, like a chromosomal microarray or a whole genome or a whole exome sequencing. So I talked about whole genome, whole exome, and the targeted gene panel. So what is done is that the cells are cultured and DNA is extracted from these cells. So the samples that are currently being utilized for these kind of genetic tests are either the venous blood samples. There is also the evidence now that people have been successfully able to extract DNA from dried blood spots, the leftover dried blood spots from the newborn screening filter papers. So DNA is extracted, the DNA is fragmented, then the areas of interest are multiplied, and then they are sequenced and read. When we talk about whole genome sequencing, it is looking at all the coding regions as well as the non-coding regions. So the introns and the exons are being looked at. Exome sequencing is only looking at the protein coding regions of the genome or the exomes. So this constitutes about 1 to 1.5% of the entire genome only. Targeted gene panels have a quicker return time because you're looking at specific genes of interest. And so the depth of investigation is better, the turnaround times are shorter, cost is lesser. So new generation sequencing, the NGS technology, like I said, is based on multiple parallel sequencing. Multiple segments of the genome are multiplied and then examined. And the most widely used application of new generation sequencing is the whole exome sequencing. Although it accounts for only 1.5% of the entire genome, about 85% of the known disorders can be identified with whole exome sequencing. Like I said, these techniques are used to identify single gene defects. So what are the indications for new generation sequencing in the NICU? Life-threatening critical conditions which lack a clear medical explanation, severe organ disease of unclear etiology, severe congenital malformations that are not consistent with any currently recognized syndrome, severe unexplained neurological signs, and metabolic failure of unknown origin. So these are the indications for new generation sequencing, which could include a whole genome sequencing or a whole exome sequencing in the NICU for an index patient. So what we talked about so far refers to genetic testing. So when we talk about genetic screening, the context is different. So genetic testing refers to diagnosis of an index patient with a clinical phenotype which has, just give me 1 second. Yeah. So with a clinical phenotype which is abnormal, which has driven this diagnosis. Whereas genetic screening, you are looking to diagnose genetic disorders in a population that is otherwise normal, is going to be predominantly normal. So that critical piece of clinical information, the clinical phenotype, that is missing. So with technological advances, genome sequencing has progressively become cheaper. And as you can see, the cost has dramatically dropped over the past few decades. In the year 2015, the cost of genome sequencing has dropped to as low as $1,000 per genome sequenced. And the cost is expected to keep dropping as the time and technology further advances. Simultaneously, we'll just go through the landscape of newborn screening and how that has changed. We are all well aware about the advances in newborn screening, and we have discussed this, I'm sure, previously as well. But newborn screening programs effectively came into place somewhere in the 1960s when they began screening for PKU. Thereafter, in the 1970s, several other disorders were then added to the list. And in the 1990s, with the advent of tandem mass spectrometry, multiple disorders could be diagnosed at the same time. And in 2006, the ACMG put together guidelines to have a uniform testing policy across the United States. They made a list of disorders that is now officially compiled under what is called Recommended Uniform Screening Panel in the US, and it tests newborns for about 50 odd disorders, primary and secondary. So this was put together in 2006. With technological advances, people are now speculating if genome sequencing will soon become a part of newborn screening programs. So what is the current scope of molecular technology? DNA testing in the context of NBS currently is used as a second-tier test in conditions such as CF, where you are looking for a molecular diagnosis. Second-tier molecular testing, it improves sensitivity, specificity, and also reduces the number of false positives. Molecular testing allows for differentiation between specific disorders. And currently, second-tier molecular testing is being performed for conditions such as hemoglobinopathies, MCAD, CF, and galactosemia. In the US, in one of the states in 2008, molecular testing for SCID was introduced as a primary screen. So this is the only situation currently where molecular testing is being used as a primary test.
Ma'am, can you unmute yourself?
Yeah. So concurrent with, am I audible now?
Yes, ma'am.
Concurrent with all these changes that have been happening in the landscape of newborn screening as well as genomics, The NIH put together a meeting in 2010, trying to get together specialists in genomics and newborn screening to put together a program to drive research towards evaluating the role of genomics in newborn screening. Funding was provided by NICHT and they gave them a grant of $25 million to put together this program, which was called the NSIGHT 2012. So newborn sequencing in genomic medicine and public health, this was called. And their primary research questions were the following. So the questions were that for disorders that are currently being screened for in newborns, how can genomic sequencing augment what information we are already obtaining? Secondly, what knowledge about conditions not currently screened for in newborns could genomic sequencing provide? Can it screen for other disorders that we are unable to screen for at the present moment? Lastly, what additional clinical information could be learned from genomic sequencing relevant to the clinical care of newborns? So far we have narrated, I have narrated rather, the sequence of events that have happened in genomics and newborn screening landscape in the US. We'll take a step back and talk about the Indian scenario for a bit. So in the year 2004, I think, to the best of my knowledge, I think Lal Path Labs was the first lab that began screening for wide range of inborn errors of metabolism with tandem mass spectrometry. And in 2007, NIMHANS began offering similar services. At the present time, there are numerous private as well as public laboratories that are offering a variety, a plethora of tests, that screen for a number of, there are varying panels available, and some of these panels are as extensive as the recommended uniform screening panel of the US. But currently, there is no state-run universal newborn screening program. And this is evident given the healthcare expenditure and our healthcare budget. So just a quick look at the numbers. The 2019 Indian health budget was approximately 9 billion US dollars, allocating about 6.5 US dollars per capita per year. The total cost to perform just one screening test for congenital hypothyroidism for one baby on a dried blood spot by using an ELISA technique would cost about $5. Adding on additional tests would cost another 1.5 US dollars. Assuming that we want to screen all our babies per year, that would be equivalent to 1.2% of our entire healthcare budget. Given that we are still grappling with issues such as prematurity, low birth weight, birth asphyxia, infections, screening and diagnosis of relatively rare disorders is definitely lower down on our priority list for healthcare. So like I said earlier, we have competing national healthcare priorities. Our healthcare budget is limiting. There's also lack of awareness among physicians, parents as well, about the implications of newborn screening or the benefits of newborn screening. Lastly, pragmatically speaking, diagnosis is only the first step. There needs to be the infrastructure for treatment, follow-up and ongoing care of these diagnosed disorders, and all this costs money. So diagnosis is only the first step. So of course, keeping our healthcare priorities in mind, newborn screening as such is lower down on the priority list. These are some of the state-run programs in the states of Chandigarh, Goa and Kerala, very scattered programs. These are the only few that I could find that have been running on a consistent basis. Some of these are government run and some of these run by private and public partnership. But these are some of the state-run newborn screening program. So while we are still grappling to establish a newborn screening program for metabolic disorders, integration of genetic screening into a public-run program seems quite far away, at least at the present juncture. So going back to this same graph that I showed you, probably we are somewhere here. We do have the technology, but we have nowhere implemented a uniform screening program for our entire population. However, what we must recognize is that there is a dichotomy. India is a country of haves and have-nots. There are people who are capable of affording the entire 50 disorder screening test. And should genome sequencing become available or should it become the norm in the West, we will have a significant chunk of our population who will be ready to pay for these tests. So what is the application of new generation sequencing in NBS? So the current applications as they are thought of is that predominantly we are looking at it as an adjunct to enhance the utility of the current metabolic profiling that we do with the newborn screening, to clarify borderline results and to detect milder variants which may not require treatment and may spare parents and the child significant psychological distress. As a first line test, they could be used in disorders which do not have a good biochemical marker, which do not lend themselves to a biochemical assay. Those disorders could be screened primarily with a genome sequencing. The two ways of doing this is that the whole genome can be sequenced or targeted approach. What most authorities are advocating for is the targeted approach, because the targeted approach is cost effective, the turnaround times are shorter, and only genomes or only the genes of interest will be evaluated. And it also gives the parents some amount of control on the information that they will be receiving. In terms of they probably they will not have access to information that they would rather not know. So looking at the recommended uniform screening panel, you will see that most of the disorders that are being screened for do have a genetic etiology. So they can be tested genetically. Most of them that are currently being screened by a metabolic profile, except for these four, that is congenital hypothyroidism, congenital heart disease, hearing loss, and severe combined immunodeficiencies. Even when we talk about hearing loss, 50% of hearing loss is genetically determined, of which some is syndromic and 70% is non-syndromic. So there is potential to even screen for hearing loss with genetic tests. Disorders that were not included by the ACMG in 2006 in the screening list because they did not have a reliable test. Among these, you can see most of these, except the ones that I've highlighted in yellow, most of these have a genetic basis. They can be genetically diagnosed. But for the lack of a reliable test, these were not included by the ACMG in 2006 in the newborn screening program. So this is another potential area where the NGS could contribute and help with early diagnosis of these other disorders. Disorders like hyperbilirubinemia, type 1 diabetes mellitus, and biliary atresia have multifactorial inheritance. So they are not amenable for genetic testing. So is it time now then? What we call, these are the three essential parameters that we include in newborn screening. So is it really time to have genetic testing as a part of our newborn screening programs? So some of the feasibility studies that were carried out, I will enumerate. This is a study from the NHS where they, what they did was they did a targeted gene testing. They looked at 5 genes coding for PKU, MCAD, cystic fibrosis, TSH, and sickle cell disease. The DNA was a dried blood spot extract, and the turnaround time for a whole exome sequences for the targeted NGS was just 4 days. They had good specificity and sensitivity, however, costs were prohibitive, and the authors concluded that at this time it was not feasible for genetic testing or this NGS, even a targeted panel, to be included into the regular newborn screening panel. Some of the other studies that have looked at the feasibility of dried blood spot DNA extract for whole genome as well as targeted panels are enumerated here. And they all went on to conclude similarly that the sensitivity and the specificity were good. The concurrence with tandem mass spectrometry was significantly good. However, the costs were prohibitive at this time. So this is one important study. It is called the newborn sequencing study, which was part of the ENSIGHT 2012 program. What they did was they took the dried blood spot, archived dried blood spots from 1,700 newborns with diagnosed inborn errors of metabolism in the state of California. DNA was extracted from these dried blood spots, and a whole exome sequencing was run on these. The research questions were, could exome sequencing replace tandem mass spectrometry as the initial screen for inborn errors of metabolism? Secondly, could sequencing augment the information from current screening and improve case resolution? So what they found was very interesting. So here, what you're seeing here is the green panels are where the exome sequencing identified the inborn errors of metabolism. And the brown panels are where tandem mass spectrometry performed better than the exome sequencing. So overall exome sensitivity was 88%. However, what is of concern here is that exome sequencing did not identify some of these disorders which were picked up by TMS. What this goes to show is that the identification of certain pathogenic variants alone is not a good way of diagnosing a disease. It's not a perfect measure of diagnosing a disease. 1/3 of the variants that were found during these exome sequencing had no previous record. So they were not, the clinical significance of these variants was not understood. So genome sequencing or the exome sequencing failed to identify some of these disorders, leading the authors to conclude that WES or the exome sequencing worked as well as current TMS for some disorders. However, for many conditions, it was less effective than tandem mass spectrometry, and that it could be used as a useful second-tier test to reduce the number of false positives. So the final conclusion was that it is unsuitable as a sole newborn screening modality. It will definitely not replace TMS, but it can possibly serve as an adjunct to provide additional information or to clarify the results that we obtain from a tandem mass spectrometry. Some of the challenges that people have talked about repeatedly, there are significant ethical, legal, social issues that come into play when we talk about genome sequencing for a newborn, generating a sort of genetic report card, if you will, at birth. Some of the challenges that people have talked about are child autonomy. The child's right to not know is compromised when the parent seeks entire genetic information. Psychological impact on families when you release a whole load of information is generated. So psychological impact on families when you release information such as carrier status, the possibility of development of a disease which is probably adult onset. So there is significant psychological impact on families with this. There's also responsibility towards biological relatives. Detection of a carrier status in a newborn could well mean that the information be disclosed to the parents so that they get tested themselves. And the confidentiality of genetic information is very, very important because this information will be stored. Data privacy, data storage are major concerns. Incidental findings that could be picked up during these genome sequencing, like consanguinity, non-paternity, all these are other legal issues that will come up. And insurability. So although there is a law in the United States that says that genetic diagnosis cannot prevent the insurer from not allowing health insurance for a particular child. However, looking at what the scene or what the scenario might look like 20 years down the line, the detection of a carrier status or the detection of a predisposition to develop a certain carcinoma might preclude these children from availing health insurance. Lastly, what information to report? A lot of information will be generated once you do a genome sequencing. All genetic authorities or societies currently say that reveal conditions that are preventable and actionable during childhood. Now, when you say actionable during childhood, we'll talk about that. Actionability is a time-related concept. So what they are saying is reveal this upper quadrant here, reveal information only about disorders that present in childhood and you can do something about them. Reveal only this information. Do not give the parent information about an adult onset medically non-actionable disease where nothing can be done about it and you cause them significant psychological distress. So reveal only this information is what most genetic authorities are saying. However, actionability changes with time. With time, what is now non-medically actionable may become medically actionable. Thereby, you become the keeper of all this information. So some of the impacts on healthcare system are this enormous amount of data generated, data safety, storage, privacy. Data storage itself is an expensive endeavor, and to store this for decades together till the person's lifetime would be an enormous exercise. Secondly, these results would have to be interpreted in context, and it would become the physician's responsibility to ensure treatment and follow-up should there be new treatments coming up for disorders to which predisposition was discovered earlier. Healthcare professionals currently have very limited training in genetics, so that would be another upheaval that would be needed. The physician will then become, like I said, the keeper of genetic information for a particular individual. And tracking systems.
Ma'am, can you unmute yourself?
So we would have to change the way we practice medicine in terms of looking at patients in demographic groups with age, gender, racial profile. We would rather have to probably club them together into particular genotypes, susceptibility groups, medically actionable, medically non-actionable groups, and take it from there. So the entire landscape of medicine may change with the advent of personalized medicine. So, are we at the threshold of personalized medicine? Probably we are not yet there because there are significant ethical, legal, and social issues. A public program that encompasses new generation sequencing with genetic screening for every newborn at birth is unlikely at the current time. However, direct to consumer testing may begin and is currently available all over the world. Even in India, there are around 20 odd laboratories which are offering whole genome, whole exome, clinical exome sequencing. So should that become a norm in the West, once again, there will be significant number of people here who will be ready to uptake and go ahead with this testing. So yeah, thank you. Dr. Prashant? I'm done with my talk. Thank you so much for this opportunity. Thanks a lot, everybody.
Prashant sir. Prashant sir.
TEJAL, I think Prashant, he should be there, but it was a very good presentation. Thanks for a comprehensive state-of-the-art lecture, really. And you have given up-to-date information on the genetics, newborn screening, and all the other things.
Thank you, sir.
Very, very good presentation. Prashant, are you there?
Prashant.
Hello, Prashant.
Yeah. Hello, sir. Thank you.
Good afternoon, sir.
Thank you, Dr.
Wonderful presentation, as usual.
Very interesting presentation, ma'am. To know all the things of what are the inner aspects of newborn metabolic activity, especially. Wonderful talk on both the subjects today.
Sir? Yes, sir.
Prashant, over to you.
Yes, sir.
Today is last this thing. You just tell everybody thanks and this thing. And I don't think I have not seen any questions till now.
There is one question for Anil sir, that was posted here. I'll tell you, sir. I have a query in the ethyl malonic aciduria. The exome sequencing is not showing any mutation in the gene. Was any deletion or duplication studies done? Dr. Uma has asked the question.
Yeah, hello.
Yes, sir. Yes, sir. Please, sir.
Yeah. No, this deletion duplication study we had suggested, but parents were very fed up with genetic studies and they said we don't want anymore. But they had done 3 times. 3 times they spent money on genetic studies. And you can imagine this is their 5th child and they have lost 2 kids before. So their prime aim was to treat this child, and then if necessary, we will do it in future. The mother is not going to go for pregnancy anymore. So this is still pending, but I don't think they will do it. But this is from Telangana area, not very affording family, and still they managed to do it 3 times from different labs, and the results were same. So their mindset was very difficult. We just managed this child with basically coenzyme Q and other things, and child is doing fine. So maybe in future they may agree, but we had suggested whole genome sequencing rather than doing deletion duplication and this. But still, anyway, whichever we do, it is going to cost them money. So they were not very keen. Have I answered, Uma?
Yeah.
Sir, can I ask one question, sir?
Yes, sir.
Yeah, please, sir. Please, sir. Go ahead, sir.
Myself, Dr. Naresh Prashad. Sir, regarding the inborn error of metabolism screening, so what should be the criteria or the importance should be given to the clinical features and the general laboratory tests which you are doing every day? What should be the red flag signs among them, so that we can suggest them about the inborn error of inborn error screening test? What important clinical features and what important general laboratory markers are there by which we can send them for inborn error of metabolism?
Sir, I think I had started with that only. If you have this presentation, I'll try to connect it. Just give me a second. So basically what we do is clinical history-wise, there are a lot of things, including clinical features, past history, the consanguinity, family history, previous children and all. But these are some of the important features. Refusal to feed, lethargy, hypotonia, seizures, hiccups, apneic spells, unusual odor, jaundice, dysmorphic features, organomegaly, and you can have one or two of them or combination of multiple features. So this will give you a suspicion that everything is not right and we may have to do metabolic study. Then we go for the basic study. What is done is ammonia, lactate, blood sugar, electrolytes, and blood gases. These 5 will determine whether we want to go for metabolic studies further or what type of metabolic studies we will do. And in the entire my talk, I had divided patients in 6 groups, where using these 5 parameters, you can put your patient into one of the groups, whether it is type 1, 2, 3, 4, 5, 6. And accordingly, you will work up. Now, this is not newborn screening. What I am talking is diagnostic screening in a symptomatic baby. If you're doing newborn screening, you have a policy, like whether you want to do only thyroid screening or whether you want to do only CAH or you do combination or you do full panel, like 55 disorders. That will be your policy. There we don't have any selection criteria that because of the past history or because of the symptoms I am selecting. So this is totally a different issue. Newborn screening is I would say, matter of policy. And diagnostic is a matter of approach. How you approach a patient based on the symptoms, based on the past history, and based on your basic biochemical parameters. Have I answered the question?
Yes, sir. Sir, what request should be done to the laboratory when we are asking for inborn error of metabolism screening? What request should be written on our prescription?
Sir, request, if you are sending for specialized test, I think the first thing is to discuss with the laboratory what is your patient like, history and everything. And if you have planned for, say, you are suspecting urea cycle defect or you are suspecting organic acidemia, you can give your view. The precaution always is to collect sample and send it in a proper tube. So these tubes are very important. Like sometimes it so happens that we collect sample in a plain tube, the clotted blood, and ask for galactosemia screening. There we need red blood cells. So clotted blood will not be useful. What I always suggest, you collect in one EDTA, one heparin, one plain, 2 ml each, and 15 ml urine. That is all required for any metabolic test. So you can send all these samples and give your clinical details to the metabolic lab. And if you are requesting for a particular test, fine. Or you can ask the lab what tests are recommended. There is a plethora of tests. Like in our lab, only we do 200 different types of tests. So you can select what is required for that particular group of patients. Precaution-wise, the sample should reach laboratory in a good condition. So it is better to put them in a thermocol box with coolant gel. Do not put dry ice. It will get immobilized. And put it in small tube or vacuum in a tube, not in a wide mouth bottle. Wide mouth bottle sample will leak out, especially urine. Sometimes we receive CSF in wide mouth bottle. It's going to leak out. So always use small tube or vacuum in a tube. Providing history, collecting sample properly, especially before exchange transfusion or any blood transfusion, that will be vital. Even if you are, say, not planning for metabolic studies and you suspect that this child may be having metabolic problem, you can collect the samples and keep it in the fridge. You can start your treatment, whether it is blood transfusion, plasma, or exchange transfusion, or peritoneal dialysis. And when the parents are ready, you can send those samples.
So, are there any specialized centers in India to manage these patients specifically?
There are. One is our center. We do it in Mumbai, but we do not manage in our laboratory. Ours is a lab and clinic. I visit many places and manage patients at their own place. Like if you have your hospital, you don't really have to shift any patient. What you need is a proper guidance, and you can talk to metabolic physician or metabolic lab, and you can manage yourself if you have a tertiary care center. What you need is basically a good ventilatory support and other procedures like peritoneal dialysis or hemodialysis you can do. There are all tertiary care centers which are managing, like all big hospitals. In Mumbai, we have, say, Lilavati or Hinduja or Rich Candy. They are all managing. So there is no specialized center which is needed. What you need is a good tertiary care center. And it can be managed easily. I manage patients even in Bihar and remote places.
So, what is the usual cost of these screening tests?
It depends on the test. As I said, the initial 5 parameters, ammonia, lactate, sugar, blood gas, and electrolytes. In a private setup, it may cost you 2,000 to 3,000 rupees. That's the beginning, first step. Once you get those results, then you start planning what you want to do. And most of the time, what you need is a good TMS, GCMS, and amino acids. In our center, it will cost you something like 15,000 to 16,000 rupees, these 3 parameters. And then there are so many other additional tests which are possible, like pipecolic acid or argininosuccinic acid, sulfocysteine. It depends what is your problem. Roughly, you can say it will fluctuate between 20,000 to 30,000 or even up to 50,000. But these are the tests which are done in, say, 1 out of 100 metabolic patients. I'm not saying 100 newborns, 100 suspected metabolic patients. So, utilization of these tests is very low in metabolic patients. Have I answered your question, sir?
Yes, sir. What samples are being sent for genetic testing, sir?
EDTA blood. First is EDTA blood. if you don't have EDTA blood by any chance, like child has received transfusion and is very critical, not going to survive, then you can use any tissue, especially skin biopsy. Skin biopsy is very good. You can send it to normal saline, or you can ask the laboratory, genetic lab, which is doing, to provide you culture medium or some other medium, transport medium. Some people have used umbilical cord also, but I would suggest either use blood or you can use skin biopsy, which are very stable. People can do it from even urine. So epithelial cells are extracted and genetic studies can be done. But it is mesenchymal. So it's not always a very good first sample. But in some conditions, yes, it can be used. Other biopsies like liver biopsy, kidney biopsy, it's not a very good tissue for a full genetic study like exome study or genome study. So you practically it boils down to only two things: either use blood or use skin biopsy. TEJAL may be able to add anything in that if she has.
The persons who are doing the genetic testing or the centers who are doing the genetic testing, are they usually do the genetic counseling as well?
Not routinely. What they expect is the physician should do it, but they have. So if you say, suppose you are not very comfortable in genetic counseling and you do not have anybody nearby, you can request those labs and they can arrange for it. Most of the Indian labs do. International labs may charge you additionally. They generally charge $200 to $300 for genetic counseling additionally. But Indian labs can provide you genetic counseling complimentary. Yeah, you need to ask them.
These genetic testing should be done antenatally or before the pregnancy or postnatally.
See, once you suspect in a child, you should do it immediately. What is our experience is many times people wait for the next pregnancy and then they suddenly come in 16th week or 18th week and then it is too late. So it's always better that you should be ready with the genetic report and then allow the parents to go for pregnancy. Before that, if you do it, like if parents go for pregnancy, then sometimes there may not be enough time and you'll have to do something in a hurry or it may turn out very costly. So it's always better as soon as you suspect, you get a biochemical diagnosis, go for a genetic diagnosis. Even if they say they don't want to get pregnant, it is our experience that then they invariably come to you in third or fourth month of pregnancy, and there's a push to karo, do something. So it's always better to at least put it on paper that we need to do it.
Okay, thank you.
Thank you.
Is there any other questions? Is there any other questions? Any participants do have any questions? What is more reliable between dried blood sample or whole blood for serum carnitine levels? Also, if for blood sample to be sent in dry ice, which companies provide dry ice if to be sent individually, not as a bulk sample for cost purpose? Anil sir?
Yeah. Okay. So the first question, whether dried blood spot or liquid blood. For routine purpose, dried blood spot, like if you are doing carnitine, it is done by LCMS or tandem mass spectrometer. And as a routine, this is done only on dried blood spot. If you get very low carnitine level and you want to confirm whether it is primary carnitine deficiency or secondary carnitine deficiency, the next thing what we do is use plasma for carnitine, that is the liquid blood, and urinary carnitine level. So it is once in a while we do on blood or urine, but that's not the first line of investigation. So whenever we have a patient, first sample is DBS, dried blood spot. Now the second question is dry ice. Blood is never sent in dry ice. So we should just make a mention in our, make a SOP in our NICU. Do not put blood in dry ice or even ice. It will always get hemolyzed. If you want to send dry ice, that is for CSF, where we want to do either pterins or some neurotransmitters, or plasma, some very volatile kind of metabolites, or you want to do some enzymes in plasma. Then dry ice can be used. Dry ice available. Everybody, like all the cities will have some kind of company nearby which will sell dry ice. It is some 80 rupees per kilo. It's not very costly. Do not ask the courier person to get it. They will not be able to do it. What we need to do is take a big box, thermocol box, put 1 kg dry ice for 1 day of transport. So if you anticipate sample from Bangalore to Mumbai, max it should take 2 days. So we'll put 2 kg of dry ice in a thermocol box. Put your samples in a small plastic envelope, put that in a small box, and put that inside a dry ice, which is like 2 or 3 kilos. It is always sent individually. The most important problem with dry ice is the box must be labeled as a dangerous good. So there is a sticker available on internet. You have to download, print it. Otherwise, courier people will not accept it. And it is never sent as a bulk sample. It always goes as an individual sample. It will be transported by a courier company like FedEx or DHL, and it is quite costly. However, if it reaches on time, it can be used for all these analysis. Unfortunately, what we experience is by the time it reaches, all the dry ice is evaporated. So it is a little tricky in India, but it can be done, and you need to coordinate with lab and the courier people. Have I answered the question of dry ice?
Yes, sir. Yes, sir. Yes, sir. If
So
any
can
of
I
the
ask
parties,
one more question, sir?
yes, sir. Yes, sir. Please, sir.
Sir, why we are also in cases of biotinase deficiency, it is
Yeah.
treated with biotin. Why we are giving carnitine as well?
See,
And for what period it should be given?
See, carnitine is given as a supportive measure. Many of these, see, any organic acidemia, including biotinidase deficiency, they will have abnormal metabolites like organic acids in blood. And carnitine will combine with these organic acids. Here in this case, it will be isovaleric acid, which will be combining with isovaleric carnitine, and it forms isovaleric carnitine, which is seen in blood when you do TMS as C5OH. It is elevated. Now this will be excreted in urine, and this will deplete body of carnitine. So as long as child is producing organic acids, abnormal metabolites, this will be combining with carnitine and excreted in urine. So there will be depletion, tissue depletion. Please remember, blood level is not equivalent to tissue level. So even if you have blood level of 20 or 30 micromole per liter of carnitine, the tissue may still be depleted. And therefore, what we do is supplement carnitine for some time, which is usually say 6 months to 1 year. If child is doing fine, then slowly you can withdraw. But as in my case, this one child which I showed you, now this child is about 10 years. And mother tried to withdraw carnitine, and whenever she does that, child becomes more aggressive, more problematic. She doesn't listen, she doesn't go to school, behavior changes. And the moment she starts carnitine again, everything settles back. So there are kids who will need it for a longer time. We cannot anticipate or plan. We have to give it and see. And that is why we monitor once in 3 months or 6 months actual carnitine levels. And if it is going below certain level, then we supplement, or we withdraw and see how the child is behaving. If child is fine, fantastic. You can withdraw it, no problem. Not all children will need. Very few children will need. I am treating at least 20 to 30 biotinidase deficient patients. And there are 4 or 5 patients who need it. Like I have a child who is in Karnataka. He is now not child. He is, I think, 20-year-old handsome person, and he still needs it. So there are kids who need it, but not all of them.
Sir, the biotin deficiency, in case of the biotin should be given for how long period and in the same dose, or we to modify the dose later on, and it should be also supplemented with the biotin rich foods.
No, biotin rich food will not help. See, biotin rich food, whatever you give, will not be able to give in that quantity. So biotin has to be given. Most of the time, you need higher dose of biotin in the early phases when child is symptomatic. Later on, you may be able to settle with a lower dose, but individually it varies. Some children are okay with 10 milligrams, some are not okay with 10. You may have to try 20 or 30 or 40. Usually between 20 to 30, and it is lifelong. Then we don't keep on experimenting. I generally see it up to 2 years or 3 years, and after that we continue in the same dose for most of the lifetime.
Thank you, sir.
Okay, thank you very much.
Thank you, sir.
Yes.
Sir, thank you, sir. Sir, Uma here.
Uma,
Nice.
yes.
Thank you, sir. Very, very nice lecture. I really enjoyed it. Thank you, sir.
Okay, thank you very much. So, Dr. Prashant, everything over? Or?
Yes, sir. Yes, sir. I think there are no more questions. I think most of the things are very comprehensively covered. Thank you very much, sir.
Okay, thank you.
Thank
So
you, NNF Karnataka, for this. Very, thank you.
Thank you, madam. Thank you. This is just season 1 we are concluding today. Season 2 we are coming up with little more advanced talk. We are doing it on this month 21st, the first talk, and subsequently we have talk on 22nd of July. This month we are having bedside brain monitoring, the scope of amplitude EEG outside hypoxic ischemic encephalopathy. On 29th we have amplitude EEG in preterm baby, and on 5th of August we have interactive case study. These are all done by people who have worked in this field for many years and who have published articles in this particular field of their interest. So we request all the participants to kindly join us as well. It has been a wonderful 3 months lockdown with a lot of academic session. For today's talk has been extraordinary by extraordinary speaker Dr. Anil sir and Dr. Tejal. Thank you very much for doing the wonderful presentation. Kotreshi sir.
Prashant.
Yes, sir.
Hello.
So we are coming to a conclusion of
End
the
of
first
this,
season 1, sir.
Yeah.
And we'll be back with season 2 very soon from this month 22nd.
Yeah.
Sir, would you like to say
On
something?
behalf of Karnataka Neonatology Forum, and I appreciate all the delegates and all the participants are the patients hearing of our practical work and theoretical work and as well as academic work also. And really hats off to both Dr. Prashant and Dr. Dinakar are doing a wonderful job. They're sitting at there with a fixed time, very alternate on 5 to 8 o'clock. So done a wonderful job, especially Prashant. Hats off you for the activities. And unless we have a man like you, kind of care enough will not get over the credit on behalf of this academic series. And I'm very thankful for the participants. With a lot of patients sharing on these days, almost 2.5 to 3 months.
Thank you, sir. Kishore sir. Kishore Kumar sir.
Kishore, sir. Okay. Prashant,
Yes,
I
sir.
want
Yes,
to give one big presentation and clap to Dr. Naresh Prasad. Naresh Prasad is there? I think so. Because
Naresh,
he is
sir?
man of the series.
Yes, sir.
I don't know where is he. He is man of the series. Almost he attended all 70 complete 70 workshops. Workshop means classes he has attended. So very happy. So Prashant, you also made a very good this thing. All the joint secretaries, thank you very much. And Kutesh sir, thank you. Everybody's and all the speakers and everybody. Anil Jalan sir, thank you. The last batsman, TEJAL, thank you very much.
Sir, we had some disturbance. Yeah, we had almost 110 speakers from the time we started. So if you take individual classes,
Sir, please unmute, sir. Sir, yeah.
yeah. So we had total 110 speakers in last 3 months who have spoken on specific topic which has been assigned. And today was the 110th talk by Dr. Tejal of this season, which we have concluded. And total class of, if you take individual classes, we have completed 49. We were just one short of half century, and total of 110 speakers so far. So all this has happened because of the combined effort of our president, vice president, and our joint secretaries. So I request our joint secretary, Dr. Raghavendra, are you there? Dr. Sidhu, Leslie sir, Sohail Ambi, Kumar.
Everybody are
Yes, sir. Yes, sir. We request you to, sir, kindly unmute, sir. Dinakar, sir.
Big round of applause. Dr. Naresh Prasad sir, where are you?
Yes, I am here.
Sir, you are our man of the series. Yes, sir.
Man of the series.
Yes, sir. I'm.
Thank you, sir.
And you attended all the 49 classes.
And it is my feeling and gratitude to you, sir, that I have learned a lot from my colleagues and my friends which have come up. And I am thankful to the Corona also that this opportunity is taken by it. And so many things have been come up, and the things which I've read in the books also, but by the various speeches and the spoken by the various learned speakers, and they have spoken so well. And I'm also thankful to the Karnataka chapter also that they are organized such a nice way, and every speakers and every participant were allowed to speak and to listen the answers to the end of the session. And it will be a difficult time for me to pass the time in the coming time till 22 of the July this month. Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Sir, you are the only person on this earth. You told thanks to Corona. Thank you very much. Thank you. Thank you. Okay, Raghavendra, Leslie.
Sir, we are here, sir. We are always with you.
Yes. Ambi, Suhail Ambi, Kumar.
Yes, sir. Yes, sir.
Leslie. Thank you very much, Leslie, Kumar, and Raghavendra, Sidhu. Please, I need Leslie, please, you are senior. Can you speak few words?
Yeah, Dinakar and Prashant is a very last 2 months, almost a very scientific session, and I'm sure I think all of us, our juniors and postgraduates, has benefited immensely, and all the sessions were good. All the sessions, all the speakers were too good and to the point. And today's speakers also, Dr. Anil Jalan and TEJAL, too good. Anil Jalan, we are in contact constantly, and he's our agent also at Manipal. So thank you very much, Dinakar and Prashant, for this opportunity you have provided. You have provided the youngsters to come up, and I think that is what is required to go further up. And please continue the good work what both of you are doing, including Dr. Kotresha sir and Dr. Kishore. Thank you very much.
Yeah, Dr. Raghavendra, you want to tell anything?
Yeah.
Kumar?
Yeah, I am here, sir. Hello. Yeah,
Yes,
just
yes,
few words about our NF Karnataka chapter, sir. Regarding I like to thank Dr. Kotresh sir, who is our president, our president sir, and I like to thank our Dr. Dinakar sir and Dr. Prashant Gowda, who has immensely put lot of work. Definitely, it needs lot of patience. Sir. Definitely, you made our NNF Karnataka chapter pan India webinar. So everybody from from Delhi, Bombay, everywhere they started calling when you are going to start again. So definitely, it's a combined effort of everybody, sir. Definitely, we are there with you, and whenever you need us, we are there for work. Thanks, one and all, sir.
Yes. Kumar, anybody, any our joint secretaries wants to talk?
Sir, Suhail here.
Yeah, Suhail, tell me.
Yes, sir. I can speak about Hubli and Dharwad, sir. The PGs have,
Yes, sir.
immensely gained from this webinars. In fact, many have downloaded the talk from YouTube, and some have requested that not to take out, take it out from YouTube, where they are very interpreted. And we thank especially Cortez and full team for having this webinar. Thank you again. Especially, taking into consideration people from North Karnataka for the talks and conveying to the full India how the new talent in North Karnataka. Thank you very much for that.
Thank you, sir. So anybody is there? Any joint secretaries? Kishore Kumar, sir.
Dinakar, sir, we are very happy with both.
Kumar, where are you?
Sir, I am here only because of all other things. They have become so busy. I'm very sorry, but it is very nice. And Prashant, sir, hats off to you. You have made us proud. Always on the. I'm serious. I'm very serious. Very good. Thank you very much. And I think we'll go. I will be more serious and we'll attend all the sessions from 21. Thank you very much, both sir, Dinakar sir and Prashant sir.
It's all blessings of Kotre sir and Kishore.
Kishore sir.
Thank you very much.
Sir, thank you very much, Kishore sir. Thank you. I missed your name. Sorry. Thank you very much, both of you.
Yeah, thank you, Kishore sir, and
last few words from Prashant.
Sir, it's been a wonderful journey because we just started that anyway. We liked academics and we were doing from last 3 to 4 years, but this format was very new and we didn't have an idea how it's going to be. So we just went ahead, and a lot of practical issues came up when we started with Zoom. They were, when we were muting all, we had to unmute, we had to request few of them to, not to interfere, technical difficulties. So I have learned a lot how to use software, Zoom, and now because of the issues, we took out Zoom from our NNF Karnataka web series and we switched to Microsoft Team, and we are very proud that we came out of Made in China app. So after using Microsoft Team as well, we had a lot of ups and downs, but now it looks like very comfortable now. So that is one part. The second part is the speakers who have been very, very coordinating. The coordination of the speakers were excellent, and we were able to give a fantastic webinar series, season 1. It's all because of the wonderful speakers from all around the Karnataka and even outside Karnataka. So on behalf of NF Karnataka, I would like to thank each and every 110 speakers who have made this program a great success. And then the next thing is the blessings of our president, Dr. Kotreshi sir. When we came up with an idea, and I called him up, I remember I called him up at around 11 or 11:15. He was awake and he was in the hospital at that time. And then he said, Prashant, go ahead, do it, academic. So his immense support and blessing has been of a wonderful help in making this program a great success. And then Kishore sir, I called up after I called up President Kotreshi sir. He was also very encouraging, and then immediately he agreed that it's a good idea to start and move ahead. So yeah, so this is how it started, and then the back backbone of the entire webinar series, and he's been my guru as well. Dinakar sir, it is a wonderful support from your side. Like how I sat all 110 talks. You were also there from our office. If you have to give man of the series, it goes to you, sir. And the backbone and the mastermind behind this wonderful webinar series. I don't have any words to express, sir. Thank you very much for being with us, being with me, and being with the entire Karnataka, NNF Karnataka. You always address NNF Karnataka as Mother NNF Karnataka, and serving the mother is a wonderful thing. Thanks for such a great, big heart, a broad mind, and a great effort with the gesture and with the position what you are in. Any doubts, anything, I would immediately call up and you would immediately respond. So thank you very much. And then coming to our joint secretaries, the young and dynamic team, we are very, very lucky to have such wonderful joint secretaries coming from North, Dr. Sidhu, Dr. Sohail, Dr. Raghavendra, Dr. Leslie sir, Kumar. They have been, and Sohail, they have been a wonderful, phenomenal support. Whenever we took on a conference call, we would talk every once a week about the progress, about the response, about the feedback, how to go about, what are the hiccups which we were facing, what we could face, anticipating the hiccups. So the background work has been fantastic and phenomenal support we got from all over Karnataka. I would like to thank my entire joint secretary, and then coming to the EB members, they have been phenomenal support. The 14 members, executive board members, who stood with us in all the talks. Thank you very much for that. Then coming to our NNFK members of Karnataka, who have been phenomenal support as well, been with us from the beginning and supporting us for all the talks. So we had mix and match of speakers from all age group. So this is something which gave us an opportunity to interact and to know our people around us. Thank you very much, sir.
And Prashant, very nice. One small request.
Yes.
See, NNF Karnataka with UNICEF, with the Karnataka government of Karnataka, and the central NNF, we are bringing out, already you announced, we are bringing out one booklet with the guidelines, completely up to date till 15th of this month. Whatever you want, whatever blood group, MMR vaccine, flu vaccine, or really vertical transmission can occur, up to date, whatever it is there. We are bringing out beautiful book. So it is once again cap for, feather in the cap for NNFK. UNICEF, they have requested very much to go ahead with the book, and you have announced, many people have sent their references. We are all concluding and we are writing the book about that. So I think so another only 2 days time is there. Please, I request, if anybody is having anything write up about that, please send to us. We are compelling and we are writing the book, and we are planning to release it on 20th of this month, but book has to be given to government of Karnataka before 30th or 14th max. So please, I am requesting everybody to support us. Kumar, you are going to support us with all the articles. Suhail Ambi, you are going to support. Raghavendra, you are going to support. And all the joint secretaries, all the NNF members, EB members, please support us for this book. And this is one. And one more feather in the cap is all the Western speakers and Eastern speakers, Eastern and Western both speakers, who have really invented and worked hard, or they have written many original articles, like this is the starting. Next about the bilirubin meter, next about the equipment, next about the ventilator, next about the echo and ultrasound. So we are planning to call all the Western speakers weekly once or twice. We requested all the foreign speakers to go ahead and give 1 hour talk, 1 hour virtual live demonstration. That we are planning from NFK. That I think so in India, nobody has done this. And it will be a feather in the cap for NNFK. Thank you very much, my dear friend. Thank you, President, Vice President, Secretary, and Joint Secretary. Over to Prashant.
Thank you, sir. Thank you, sir. A wonderful session. Anil, sir, once again, thanks from bottom of the heart for accepting the request and being the session. Sir.
Prashant, somebody wants to talk.
Yeah.
Hello.
Hello. Yes, sir.
Sir, good evening.
Dr. Sittuji.
Sidhu sir. Kindly forgive me. Just on duty. I just have listened to last part of the conversation. Sorry, sir, Dinkar sir and Prashant, I missed this session. Can I say a few words if you guys don't mind?
Please
No,
go
you
ahead.
have to talk.
Thank you, sir. Thank you for the opportunity. Good evening, Kotre sir and Kishore sir. If sir is there, hi Leslie sir, Kumar and Sohel. I want to make certain points. The beauty of NNFK is a team. As Dr. Dinakar sir rightly says, Mother NNF and we have all been the foot soldiers of this webinar. And to Dr. Dinakar and Prashant for success, wonderful, such a big event, which I call it an event because it's not an easy game to engage 300, 350 every time in a single webinar. It's been a very program and put it out really well. And it's hats off to you, sir. Hats off to you, Prashant, for really doing a great job. We being joint secretaries have missed certain times, but you guys have stood there, you have delivered it, and entire credit goes to you. Okay, and you have been generous enough to give us a part of it. But let me be frank on this, Prashant sir and sir, wonderful job. It has been great to listen to a lot of people from outside as well. So thanks to you guys, and hope that we continue to work much more and get many more things to NNFK. As Dr. Dinkar rightly said, the concept for COVID-19, it's a great thing. Looking forward to work with you, Dinkar sir and Prashant, in that aspect, so that it will benefit.
Thank you, Sidhu, for accepting as in the expert group. Thank you.
Sir, it's been honor and it will be a privilege to work under you, sir, all the time. Because the dedication, the sincerity with you, which you work, has taught me a lot of lessons in life. It's not an easy
one
job.
More thing about AEEG, you will be the panel. AEEG, you will be in all the panels. 22nd, 29th, and 5th. You will be a panel discussing person. Okay, yes, because Jody More especially asked about your name, Jody More and Carl. Especially they want you to be there.
Sir, whatever you say. Sir, whatever you say, we will be there, sir. And forgive us.
Jody More still remembers Sidhu Charki.
That is because of you, sir. Because if you remember, we had met him in the first National Neurocon. And we had good time with him.
Jody More, I am talking about she.
Sir,